Our first step will be to put our posterior portal in. And so we feel the back of the acromion. What I like to do is just feel the joint. So I'll shift the joint back and forth, lift it up a little bit, and then we'll pop that in into the shoulder.
Do you have traction
This
on
is
right
the
now?
Arthrex. I'm sorry?
Sorry, do you have traction on the shoulder right now, or do you put the
Just
scope
a
in
little bit,
first?
not very much. It's a spider, so it's not, I trained with an arm holder where we put actual traction on, and we use 5 to 10 pounds. So this is our diagnostic shoulder scope. Superior labrum here, absent biceps, there's the cuff. Superior labrum here, middle glenohumeral ligament, subscap. We always pull back. JCU has described a little dimple where you can actually move into something. That's not this. This looks pretty normal. There's a chondro defect. That looked old to me. That's usually an impaction lesion from the coracoid. We can lift up so there's no inferior capsular contracture, and indeed you can see the head sitting down, so we don't need to do any kind of an inferior release. We come back up at the superior labrum, rotate up, and find our cuff, and there's our tear, and we can actually drive up and all the way through. So small, full-thickness tear in the rotator cuff. So that pretty much completes the diagnostic scope, so we don't have to do anything. We'll move up to the bursa now. And, sorry, I had to reach back a little bit. And so I just kind of sweep in. I go lateral more than medial. I think it's always a risk if you go too medial that you'll get into the rotator cuff. And so I'd rather be out over here. Now, I will tell you that before we got started, I did clean this up a little bit and do a decompression. As you can see here, there was a lot of fraying on the lateral acromion if you look at the inside view. And so we took that back and tried to change her critical shoulder angle. And if you look down at the cuff, it looks pretty good. It's not really retracted. Grab her. And you can put a grabber in. So we really haven't done any debridement of the cuff yet, but we can put a grabber in, and you can see how really there's not a lot of tension on this. We could pull it further over if we want. We don't want to yet, and we'll show you some other things. So we can take our shaver and clean off that underside flap that you were able to see from inside, and we'll do that very quickly. And just make sure that it's pretty smooth, and it's not a problem here. We want to make sure we can get all the way down the shoulder. She had a minimal amount of bicep symptoms, so you can always come around here and take a look down the bicipital groove and see, as you see here, if there's anything more we want to do. Here's the groove. Really not much going on there. No real tendon, a little bit of a tendon, but not really any synovitis or anything we want to deal with. So we can leave that alone for now. So here's our cuff, and we'll clean up the greater tuberosity a little bit, and we'll make some trephination holes in a minute with our awl. So then we're finished with this part. So normally then, you're going to move your scope, to the lateral portal, and you would come in from the back and clean up and see what your angles are for fixing this in terms of how we, thank you, how we're going to pass our sutures. There we go. So we'll back up and take another look at the cuff, and you can see how the MRI was very accurate. It goes right into the infraspinatus. We'll bring our shaver in from the back and kind of play with it a little bit and just see if it's really kind of an L-shaped tear or a little oblique to it. And so we really want to bring this part back to here and this part straight over. So a little bit of an L. We can look back here, and you can kind of test, because I like to do retrograde retrieving, what you're going to use to pass your sutures. We do want to clean up a little bit over here at the medial side of the acromion. And then here's where our CA ligament is. We haven't actually cauterized it yet. We'll do a little bit more there in a minute. But you can see how we just clean up over here. Here's the spine. And so we feel pretty good about passing our sutures. The one thing we might want to do is use the spinal needle and kind of see if maybe a Nevisor portal might be a good way to pass some sutures. So here's our spinal needle coming in here. So that would give us a nice straight shot on passing sutures should we want to. So we'll put a little puncture there for in the future. Can you look on the outside and see where this is?
Yeah, we can see that very well.
There we go. So you can see right here on the outside, so you can see the needle come in. So we'll save that for later. We're not going to do that right now. We'll do that in a minute. So our next step is to make an anterior portal and go look at our spinal needle. Thank you. Is kind of look at the front and just make sure that we can get this in where we want, and we can, so that's a good portal. A little bit lower than I had drawn. I think I'm not used to using a pump. And so cautery. The cautery is here.
Hey, what are your thoughts on the coracohumeral ligament?
I'm fixing to go show it to you right now. So I think almost no matter what, you want to release that. So here you see the conjoint tendon coming right here. I'll tell you what, let's put a shaver in and I'll clean that up real quick so you could see it better. That's not really a good view of it.
Now, with your
And
bursectomy,
so we want to come in with this one lateral to our CA ligament. We'll come back here. So there's the CA coming in. Here is conjoint tendon. So if you think, people do get partial tears in that, especially gymnasts, and it's a nice way to fix it. And if you like Steve O'Brien's way of doing the moving the biceps to here, you can do that. But that looks pretty good. The second thing is to check for a coracoid spur. We really don't see much going on there. And we can kind of move over a little bit now and come more medial and clean this off, and we'll get right into coracohumeral ligament. That's this big structure here on the base of the coracoid. And so you can see here, it's very thick. And one of the things that it helps is, we know that oh look, you know what that is? You see this right here?
oh, yeah.
This is a congenital variant. That is an accessory pec minor tendon. See that on top?
Yeah, we
I'll
can
clean
see
it
it
off, you can see
beautifully.
better. How exciting. That's actually pretty rare. I think it's about 1 in 50, 1 in 100 cases. The last time we looked at our numbers. So we see it a few times a year, but that's an accessory pec minor tendon. You don't have to do anything with it unless they're dyskinetic. And if they're dyskinetic, you can release it. Can you see that?
Yeah, we can see it beautifully.
Okay, accessory pec minor. That is so cool. All right. So it's a rare thing. I actually wrote that up in a book of Brian Cole's on rare lesions of the shoulder, that if they're having coracoid pain, you can release that and eliminate that coracoid pain. And if they're dyskinetic, you can also release it and they'll do better.
Would you have to release
so
it if
you-
you had
you
trouble mobilizing this tear? I mean, not in this case.
If I was going to have trouble, yes. But releasing coracohumeral, we'll cut it. So watch what happens. There's no harm in cutting it that I know of. I haven't found. And so here's our coracoid. You know, if you're going to do an anterior interval slide or a nerve release, you could come past it. But if you think this is a problem, if you think she's dyskinetic, she leans forward too much, there's no harm in just cutting it. It's accessory tendon, so you're not going to change anything, and then it'll help you bring your cuff over a little bit more if you need to. So accessory pec minor tendon, you can see where we took out that little hook on the coracoid where that impact lesion inside the shoulder came from. So then we kind of done everything we need to do. So time to fix. So we're going to back up and look at our cuff. We'll get our spinal needle.
Buddy,
Let's go.
this is
She's
JC.
awesome, huh? You are very lucky. Yeah.
Buddy, this is
Yes.
JC.
Yep.
I encounter those aberrant pec minor tendon quite often, more often than you describe, and I published this
Yes.
in the JSTS. But I think 1 out of 10 person I find is pec minor. It's just that we don't look for it.
No kidding.
Yes. So, what's your thoughts on that?
So I look for it because I release coracohumeral on everyone, and so I think it may be in the U.S. a little less frequent than that. So do you usually take it, or do you usually leave it alone? JC?
Yeah. He's coming. He's trying to get to a mic.
Oh, sorry.
Okay. Usually I cut it when I'm doing a rotator cuff repair because I think it tethers your repair. After if you repair it, you can see it kind of tethers. It's usually inserted in the rotator interval or the supraspinatus anterior margin, so it's an aberrant, and I'm not sure if it has some role on the repair or on your exercise post-op. Do you cut it?
Yeah, I usually do, just because I don't want to have an additional pain generator, and so many of mine, let's put one more here just for blood supply purposes. Okay, that's plenty. Okay, all right. So now we'll put our anchor in. So here's our first anchor. This is the Mytech Helix. It's BioCro Repeat Anchor. Usually turns the bone in about 24 months. Pretty good. It's got some tricalcium phosphate in it that helps. And so there's our sutures. So now we'll come in back here, and we've already checked to make sure that we can pass from back here. So we'll start And if you look at it, we'll need one kind of mid-infraspinatus here, medial to that tear. And we'll make sure that we don't offload our anchor. And then we'll do a second one coming around the corner. So if you think of this as a big ellipse, we're just trying to keep moving around. So we kind of take this and drop into the joint, come over. This is the one we want that matches that one. It's nice when you have an excellent surgeon being your backup. I tell you what, that is so nice. I think we can get one more from this portal. Hang on one second. Can I have a hemostat? Hold that for a second. Hemostat?
Technical issue.
Yeah, I'm Jin Young Park from Korea. When you see the delaminated tear in the infraspinatus, what do you do during the operation? Do you cooperate or do you repair separately?
Can I have another one?
We'll just wait just a moment until he fixes the instrument here. Buddy, we have a question for you, but you go ahead and fix that instrument and let me know when you're ready.
Okay.
Certainly, I can answer that question for
we
myself.
just do
What
one.
I would
Okay,
do.
so what I'm doing is I'm going medial to the delamination, right?
Yep.
And so what I'm going to do, if you look under here, I'm going medial to the entire delamination. I want to bring this undersurface part back to this medial part without changing my mismatch. So I'm going through the tendon obliquely so that I put those two together. And then we may double pass in a minute.
Thank you.
I noticed, buddy, that you put that medial anchor slightly more anterior, and I know that was by design, but can you explain that for me?
Sure, it's an L-shaped tear. I want to move the whole thing over to the front. So tears pull medial and posterior. So I want to make sure that when I do this, that I change that vector. I want to pull this upper infraspinatus back up. You see I changed portals where I was retrieving from? Did you see that?
I think I missed
So
that.
I'm coming in from the top.
Oh, yeah,
Now,
we can see that there
and
through
even
the
without
visors.
taking out the AC joint, I can still come over. Now, as I move more forward, I got to move a little bit more lateral. So we're going to come back over here because there's no delamination here, and I want to be a little cautious, but I still want to be medial to my undersurface part of my tear. And then we just make sure we don't offload that. Okay, and then we have one more. So I can either come from here or I can come over from the front, take a look at it and go, I think I want to bring this over just a little bit. And this is a nice way to do your biceps if you want. And then, oops, sorry, my bad. So then see, I'm always going medial to the undersurface part of the tear. So now we'll take our smaller cannula and put it in our superior portal, and we'll take either a crochet hook or a magic grasper and start tying. So, look at a nice crochet hook. Isn't that sweet? That is so nice of them.
So you like to tie that medial row first?
I am a knot tyer, so I like to tie. So for me, I like to tie knots. I know it's not the same for everyone, and there's some compelling evidence that maybe that's not the best thing in some patients, but my goal is to make sure that I get my medial row stabilized. Okay, I will tie. So can you hold that for a second? And then we decide which one's going to be our post. We want the front one to be the post on this one. So we're going to change because when we do our second row, so we want to pull this front part up to the anchor. What we should be able to do, can you put a finger right there for me? Thank you. What we should be able to do is close off the joint just by tying our medial row of knots. And so we'll pull all this in. And you can tie back to front or front to back. I don't think it matters. I used to think it did, but now I don't. I just hadn't noticed any difference. And so here we are, we're putting it down, and we'll tie this. And make sure that our front part of our supraspinatus is back where it's supposed to be. And then we'll cut one of these and save one. And this is orthocord suture, so it's really nice. About half of it dissolves. Okay, so let's see. This goes like this. Oh, sweet. That's my first time to use that. So do you have the trocar, orange trocar for the knot pusher? Thank you. Crochet hook back. Those are a little close. See that? I made a mistake. Uh-oh. Okay. Let's have the other grasper. No. The magic grasper. Lobster claw. Perfect. Yeah, no worries. I dropped it. It was completely my fault. But see how these are a little close together? These should have been further apart. So that's the front one. That's in supra. This is the back one. That's in infra. So then we'll tie this one. Thank you. And the suture this time will be on the front, and in the back one, it'll be on the posterior one because we want to make sure we shift that up. And this is a modified rotor knot. If you go outside, you do a two-handed throw, pinch over here. 1, 2, 3. The nice thing about this is no matter how far apart it is, it won't back up once you push it down. So it really gives you good holding power.
It's a sliding, non-locking knot.
It's a sliding locking knot. It's going to lock.
It's going to lock?
Lock very well. So if we back up a little bit, you can see how now you can't see the joint anymore already, but we have that delamination of the infraspinatus that we'd like to close. So see how it moves it over? So you know we released that coracohumeral, which gives us tons of length. And so now this is going to really lay down nicely. And the question will be, she's got a very small tuberosity, so you really can't put a bunch of anchors in my opinion. So do we want to put our anchor, our second row on top, or bring it around the corner? And we really don't have much real estate to play with here. Trocar? Ah, you're so good. Thank you. You should come home with me. Isn't that nice?
Careful,
They're
buddy.
very good.
You're live.
I'm recruiting people. So, all right, so let's see what we have here. So here's our one and second one here. That's the back one, and the front one, I think, is right over here.
Now, is there a reason why you chose to cut one stitch? Because I believe this lateral row anchor can actually hold up to 4 sutures.
It can hold 4. So, yeah, so I'm going to put 3 in it. If I was going to do 2 medial anchors, if it was a big tear, I would do something like that. I might keep the middle ones and crisscross them. But because of how we put the anchor in anteriorly, when we bring our lateral row a little bit more posteriorly, it'll be a centimeter back and a centimeter down was sort of the plan. Then that should actually pull it back and right over the top. So now we have this all closed, see? And so we have 3 mattress stitches. So essentially that's a single row, it's all closed. Doesn't look bad. And so the question is, this lateral part is what we want to make sure we take down. So we could keep one if we wanted. I'll tell you what I'll do is I'll keep one, I'll show you something. All right, so let's leave one there.
George,
I'm going to
think
get where you are for
he's going to
just a
fish it
second.
too fast, so you can ask the podium
I got
to
it.
ask questions.
Well, we've got a wonderful faculty
And so
here.
what we'll do now is we'll come in from the front. So say you don't like something about this, or you think your lateral row
JC,
is
why don't
a
you come
little
up here
bit,
and join me?
a little bit off. So we'll come in here. We're just going to work on the lateral row. We'll pop down. We're going to turn this over.
Buddy, can you slow this down a little bit? We still got some time.
He has to catch
I
a
don't know.
flight 310.
Sorry.
He has to catch
We'll
a
go show
flight
you
310.
something else if we
Yeah.
finish too quick. So I'm adding a step here. So this is coming through, right? And so what we'll do is we'll take these sutures, but you're coming out here. We'll move one of them way over there. Can you hold that like that for just a second? No, this one. Just keep that pushed down. Let's see. Let me have the lobster claw grabber for a second.
Buddy, you're doing a left shoulder.
I'm
and,
slowing down.
Yeah, you're doing a left shoulder, and are you right-handed?
I can change hands. This is surgery. I don't. It's not a hand thing.
But what I'm trying to say is that left shoulder for right-handed is a little bit more different. I put my portals different from my right shoulders, which, do you have any opinion on that, or do you do differently from right shoulder to left shoulders?
No.
So
I think,
that means you're bidextral, or you can use both hands.
So Dr. Kasperi said from the very beginning of my training that if I wanted to be a good shoulder arthroscopist, I could not be one-handed or the other.
Can you
and
use
so I
left
had to
shoulder,
be-
left hand chopsticks?
I was going to ask,
Actually, I
do you brush
can.
your teeth with your left hand or your right?
It depends on what hand was weaker the day before. So I eat about half a meal right-handed, half left-handed. I brush my teeth left-handed usually. Can you hold that right there now? And then,
You sure you're not left-handed and you were forced to do right-handed stuff growing up?
Yeah.
I don't know.
So that's my point. I might
Okay,
be biased.
let
There's
go.
no evidence, but the left-hand people have both hands very good, whereas right-hand dominant people have left hand weak. So it just kind of makes left shoulder a little bit more difficult than right shoulder.
It's interesting, we talked about switching your portals from when you're doing a left shoulder. I don't do that with rotator cuff
Yeah,
repair,
I don't-
but for arthroscopic lat G, I do make different portals when I'm operating on a left shoulder.
See?
Oh, can you hold these for a second so I don't tangle? So what I did is I passed it so I can use that other one to make another stitch. And now we'll pass all these around. So then they're all sitting up here. So then we got to decide where we want to put our lateral row. So it looks like we could put it right here without too much trouble. So I think that's what we'll do. We'll hold those for a second. We'll take the awl. So let's switch places for just a minute. I tell you what, let me clean this up a little bit so they can see better. So I think we're going not fast enough. It's we have a little bit of extra swelling over here. See? So that means I'm going too slow. Okay, now we can see better. See, it's a better picture. So I'll come here. You come here. Okay? So, oh, no, this first. Oh, I have to change cannulas, right? That won't go through this cannula. Technical error, sorry.
If anyone wants questions, all the podium mics are open right now, so you can come up anywhere and ask questions.
Thank you so much.
Well, buddy, I was going to ask you a question with this critical shoulder angle. When you did your acromioplasty, is your goal to change that, or is your goal?
I do. Yeah, we got a paper we're working on right now on it. I just learned this from Christian. I got to give him all the credit in the world. I've kind of always worked on the lateral acromion, but it was not based on any science. It was just based on the fact that I would see fraying, so I would take out the fraying, and then the Christian put the science to it, and it makes perfect sense now, to me anyway, that's what I needed to be doing. And so what I'll do is I'll look in the joint and or look in the bursa, and then I'll take out all the part that's frayed and see on my post-op x-ray did I change the angle. And actually we do. So I kind of bevel it up a little bit. I try to stay out of the deltoid. See the fat bubbles coming out where we made the trephination holes? Isn't that good? Mm-hmm. So that's our stem cells coming out to help it heal. So then we know where our hole is. And so we'll take our footprint and we'll feed all these stitches through there.
Can you show us outside?
Outside view, please. 1, 2.
So this is a helix.
And this is a helix knotless to recreate our footprint.
Can you arrange the camera angle? 카메라 좀 조절해 주세요.
and a short one.
Yeah, JC, I can't say that, so I'm glad you're up here. So what's that little white disc there?
So that's for cleating your stitches. I'll show you in just a minute. Okay, so now we have, can you grab that? So now we have all 4 stitches coming out of here. Are we outside? Yeah.
Yep.
Okay, so the little white disc is you can kind of dock your sutures and separate them if you want, so that it's not a problem. Now we'll just slide. This is going to stay on the outside, and so what we'll do is we'll just slide right down our stitches, so you see them all coming in,
Can we see inside?
and we'll put this, go back in. There we go. And then we'll push that in. Make sure our stitches are about as tight as we want. We can individually tension at this point, should we choose to, if we need to, and then you can actually cleat it if you want, because we haven't done anything with it yet. So we could cleat it if we want, but you got to maintain a little bit of downward pressure. So see, I can do that, then I can put it in the cleat, because now it's tight, so I can individually take each suture, make sure it's tensioned, see how that's pulling down? You're inside, right?
We'll go back onto the inside view,
And there's
please.
our last one.
That looks great.
Now if you go outside, you can see that all these are in the cleat. Outside?
Outside.
Outside?
Can-
So now you see I have them all in this little white cleat
we-
that you were
can we
talking
zoom?
about?
Zoom.
Here we go. Hands away.
Zoom. Can we zoom? 줌 안 되나요?
Okay. Oh, wrong
The
way.
other-
All right. So let's move on. So then when we get ready to put our anchor in, we push it in. We have to take all of these out, and then we'll screw it in.
How much tension is too much?
Well, you know, Hawk did a study in Greenville about pulling it too tight. And so I think that I just barely pull it so that it cinches down a little bit. So it's a good bite. And then we'll come back in here.
Inside. Outside.
Now, if I needed to, I can use those sutures, or I can use this suture on the inside. Oh, sorry. Outside.
Outside.
So I could use these sutures on the outside and pass them again if I had a dog ear or something I wanted to fix. I don't, but I could. And so then we just take this out. And we'll, which one was that one? I think it was this one, wasn't it? We'll just get rid of this suture because we don't need it. And we'll cut these others. Can you do 4?
Inside. Inside.
Okay. And then now we'll take a picture, we'll take a look at our cuff. So here's our rotator cuff. We can move it back and forth. It does very well. It's not bunching up. There's no undue tension. You can adduct it and abduct it to make sure it moves. There's no more lateral impingement to cause a problem. We don't have to do anything with the AC joint. We've released our coracohumeral. There's our conjoint tendon. And so then we're done.
Perfect. Looks beautiful.
Okay? Okay. Thank you very much.
Thank
so
you.
is there
Thank you
questions
very
we can
much.
answer?
Wonderful.
Are there any questions
You were
from
great.
the audience?
Thank you. Thank you.
Before he leaves,
Like whipping everywhere's way.
any questions? Okay. Well,
I got a question.
okay.
Sorry. Sven Lichtenberg, Heidelberg, Germany. Buddy, aren't you concerned to put your medial stitches too far medial as you showed them? Maybe the patients, maybe you get some overtension and the patients are more painful. Does that matter to you?
Buddy, did you hear the question?
I did, thank you. So I try to put my sutures between 5 and 8 millimeters away from the muscle tendon junction. So it's a bit harder to see on this one because we preserved the medial bursa, because I think the medial bursa is critical in enthesiopathic tears to keep blood supply going to the tendon. So we release it off the acromion and the spine and let it lay down on that muscle. But I go lateral to that muscle. Now that edge right there is supposed to be sitting right on the greater tuberosity at the articular margin. So my sutures go precisely at the point where the undersurface tear stops and the part of the tendon that's supposed to be placed right into the trough. So I would be very concerned with overtensioning. You could easily see we did not overtension it as we rotated it back and forth and abducted and adducted it. So I think, at least to me on rotator cuffs, my job is to get that part of the cuff right off to the articular surface and get that to heal.
How will you rehab this patient?
I won't be here. Sorry.
What is your,
How will you rehab? So for me, I go very slowly with my rotator cuffs. We'll start, place them in an abduction sling. We start passive motion and scapular retraction exercises early. A lot of cryotherapy. Because the subscap was fine and my lower infraspinatus was fine, I'd probably start some very easy, active external internal rotation around 4 weeks. They'll get an ultrasound at 6 weeks. If the ultrasound looks good, then 6 millimeters or more of thickness, then we'll move to a physical therapist. If the ultrasound is 4 to 6 millimeters, we'll stick with home exercises. If it's under 3, we don't advance anything at all. And then we'll ultrasound them again. If it was a good ultrasound, they get another ultrasound at 12 weeks. If it was a bad ultrasound, we bring them back in 2 to 3 weeks, so 8 to 9 weeks out, repeat the ultrasound, and if it looks better, then we start more aggressive physical therapy. But passive motion only, and we don't actually start stressing, like no active abduction, no thumb down exercises till at least 12 weeks out.
what if it's torn on that ultrasound? What if you had a larger tear and you see a partial tear, a re-tear?
Then I go back in. Then that becomes a revision situation, and I tell them that it failed, and they have the option of continuing therapy and seeing if we have enough of it stuck down, or that we would go back in and fix it and do some extra things like patches or supercapsular reconstruction, depending on why we think it failed. The rotation medical patch, there's some other things I can do. I mean, I can do convergence stitches and lots of other things if it fails early. Joe Iannotti has some great work showing that cuffs do fail early, and we go very, very slowly. That's why the 6-week ultrasound, I think, is so important.
Yeah. We have another question from the audience, Dr. Abrams.
Nice job, buddy. Question.
Thank you.
Spacing between holes. So you had a medial anchor, and then you decided laterally. You went a little bit anterior and a little bit posterior. Do you have any opinion of what's the minimum amount of space between your anchor holes, and whether or not they have to line up perpendicular to your repair, or do you like to oblique them like you did today?
Yeah, I usually, so the question is really, I like to oblique them. And for me, the question is always, where's my medial anchor fit best? So if my medial anchor is at the 50-yard line, right in the center, then I'll suture all around it. And then my lateral anchor then will need to be more anterior, closer to the bicipital groove, so I can turn it down to the front. Alternatively, or rarely, do I go straight in line, because I like to oblique them a little bit. Plus, I add the trephination holes, like I showed you, so we could get better blood flow into the cuff, or better stem cells into the cuff. So it's always oblique. And in this lady, because I thought it was more of a pulling away, pull medial and posterior, that I needed to bring it back this way for my medial row. And then the lateral row, at that point, was outside of the cleavage. I needed to lay that down on straight down. So that was a decision we made, like when we looked from inside and then outside, from the back and from the side, that's the way that one needed to go.
We have another question from the back.
If there is a lateral stump left on the greater tuberosity, how much would you leave for reattachment? How much would you resect? So how many millimeters?
So if there's a lateral stump on the tuberosity, I will leave it, and I may lay it down to the cuff, or I'll take it out entirely. I think that's not good tissue, and it's not going to help. But I also move my lateral part of the repair medially to account for that loss of tendon. So if you have a loss of tendon, the biggest mistake you can make is try to do a 4-anchor repair and pull that residual tendon all the way over to the lateral side. We were lucky here. Our undersurface could only go just off the articular margin, but the superior surface could easily come over the top, so it looked nice. But if say, that top part had torn, like you're saying, and I still had tendon, a centimeter of tendon, then that entire repair would be a centimeter medial.
We have another question up front.
Buddy, I just want to ask you, is there any role for dual row repair in today's world? Because now people are talking about this superior capsule versus the footprint. So if there is a complete differentiation between the superior capsule and the original supraspinatus tendon, then is it advisable to do a dual row repair rather than a footprint repair, which is more popular? And what is your take on it?
So I just repair the cuff where it needs to go. So, you know, if the superior capsule, which is still attached to that undersurface part, I should have showed that. I am very sorry about that. But the superior capsule was still
We
attached
got
to the
time,
undersurface
you can open it
part.
up again.
So, and take it all down and fix it again, or if you did that. But the undersurface part, if we actually, the capsule is going to be back where it's supposed to be because we repaired it. We take a quick peek. I'm going to take everything apart now. So it's a good question, and it's worth taking a quick look at if we can. With the water on.
Sorry for it.
Oh, we went out. So see the capsule? Capsule is put back, right? That's capsule you're looking at. That's not tendon. So the capsule is back attached where it's supposed to be, which is right off the articular edge. You know, that's our interval, which is still open. Our subscap looks fine. But that's the capsule there that's now pulled back where it's supposed to be. So, and it's fun to look in. I mean, it wasn't necessary, but you didn't have to take my word for it. But you put the capsule back as part of that repair. So when you look at the undersurface parts like this, the capsule is still attached to the underside of the tendon. So that goes back like this so that the capsule is attached and then the footprint is restored. If you have no capsule and the head is not up and everything is balanced, you don't have to worry about it. But if the head is up and you have a narrow acromial-humeral distance, then you may need to do an inferior capsular release. You may need to bring it down. And then if you have good tendon and muscle and the capsule is still on the tendon, then you can put it all back. If you have no capsule and you have superior migration and an atrophied supraspinatus that's retracted medial to the glenoid, you may need to do something to hold the head down, which is a superior capsular reconstruction. Miata has done us a huge service by bringing that to our attention. It is not my idea, it's Miata's. And then you can repair your cuff over the top of it, but then you take some of the stress off your rotator cuff.
So is there any role for dual row repair in today's...
I'm not sure I understand what you're asking me.
Rosen, what's your question is?
Is there any role for dual row repair?
Double row? Like what?
Not double row. Dual separate row, medial and
Oh, so
Oh,
two,
yeah. So
two,
that's,
two
so Sugaya
screws
thinks,
for lateral?
yeah, so Sugaya thinks that you should repair the undersurface part and the superior part separate. That you should put a bottom one in and repair it. It's possible if you really have a layered dissociation, then I would do that. I would repair the bottom row, I'd save the stitches, bring them back through the top row and lay them down over the top. So yes, there are times when you look in, and apparently that's more common in Japan than it is in the US.
Thank you.
Thank you. I'd like to take this opportunity to close. And, Buddy, that was wonderful. It was great watching you operate. I'd also like to
Thank
take this
you.
opportunity
Great
to
fun.
thank Professor Yu for allowing us
Special
to do this
thanks,
surgery,
yeah.
For allowing me.
and also MyTech for sponsoring this. Thank you.